So I'm going to focus exclusively now on the support for the introduction of a quality improvement agenda, and that really fits in with the QIP Learning Collaboratives. So introducing improvement for us has been also part of a journey where we've tried to look to other places that have done this work, both the experiences of other provinces in Canada, the US, the UK, and really understand how do you do this? How do you take these great concepts and really make them applicable and something that you can teach teams to do and spread and sustain as they go forward. So our framework is very similar to the one that Mike showed, where it really is that recipe, the components of how you get better outcomes, the evidence-based guidelines as being core to that, the care model that many of you continue to see, that model that's called the Ontario Chronic Disease Prevention and Management Framework, and then finally the improvement model, or the model for improvement, that again is something that many of you have probably seen before, and I'll flip up a few slides just to remind you. The method that we're using to roll all these concepts together, these three pieces, is the Learning Collaborative. And it's based on a modification of the Breakthrough Series methodology that comes out of the Institute for Healthcare Improvement in the US. And again, I think many people have been exposed to it or know about it. We put it in place in Ontario in a very specific way, but it's modeled on that approach. What we're looking at in our Learning Collaboratives to help teach the methodology is focusing on a chronic disease, which is diabetes, a preventive care strategy, which is colorectal cancer screening, and office practice redesign, which is access and efficiency. So again, you'll recall that Eileen was saying it's not so much about what the condition is, it's about learning this methodology and how you apply it in practice. So she used the asthma example and said that's what they were kind of focused on trying to improve, but they actually came to a collaborative that taught them about improvements to access and efficiency, and through that, they were able to see gains. We're taking a similar approach. We've got things that need to be the focus so that we have measures and ways that people can do the work, but our hope is that once teams learn how to do this, they can apply it to anything in their practices and any area where they really feel they want to make change and measure and see whether it works. The other thing that's part of our learning collaboratives is a support structure that includes something that we call staff that work for QIP that are called practice facilitators. There are staff that are supported centrally but are in the regions to support teams that are doing this work. We really feel it's critical that apart from just coming and learning how to do it, teams know that they have people that will be there with them to support, to coach, and to help them understand how to do this in action. So the practice facilitators are assigned to a team and work with them through the duration of the time that they're participating in the Learning Collaborative. Leadership development, as Eileen had on one of her last slides, key piece of this, you must have leadership buy-in and support for this to be successful. So we're doing things to build leadership development as part of this process as we go forward. And we also want to make sure that at the end of the day, this isn't one of those one-shot wonders that people went to. Remember when we went to that collaborative, a couple years ago, that it all sort of dissipates. So often that's the case. We want this to be work that is embedded into the work of teams and that they have opportunities to continue to participate in learning communities and share with one another as they go forward. So that's another part of the strategy. How are we doing for time? Okay, not too bad. So just to review the elements of the learning collaboratives and the things that we're teaching, there's a care model, and that's that framework that Mike was talking about. So this is really what gives us the change concepts that teams can work on. They're identifying areas where they can improve in their own practices in all the dimensions of the care model. And I think for me, that was one of those ahas. Oh, now I get how this model actually can become alive and really operational in practice. The improvement model is the other piece, and again, I think lots of people have seen this. It really is the Plan, Do, Study, Act cycles of change, helping people really to understand that through measurement, they really are looking at whether the things that they're changing really represent an improvement. And I think that's key to really moving this work forward. So often we do a lot of things, but we really never measure whether it made the difference we thought it would. And the methodology in applying this methodology, it really forces you to do that. Rapid cycle tests of change are key to what teams are doing. And again, the power of this is something I, didn't really understand because, we were looking at this, hearing about it, but until we actually saw teams doing this and being really empowered or given permission to not do those 6-month planning processes and then, reaching consensus and then maybe changing it. Teams do this quickly. They go back, they think about something that could be different, they test it in real time with a couple of patients, see how it works, study it, and then apply it more broadly if it's working with more patients. I think the other beauty of this is it allows teams to do the things that have meaning for them in their context. As I mentioned, family health teams are all different. They serve different populations. We have some from urban areas in Toronto. We have smaller rural ones. We have in the north, in Ottawa, different community systems, different health systems. We don't tell them that they have to apply a certain approach. They get to decide how they can make change within their own context and test it and see whether it works. So I think the power of that is also a really key part of this methodology.